welcome to the Sprint and blood pressure measurement session of the Sprint Expert Exchange. I'm Angelique Berg, CEO of Hypertension Canada. Hypertension Canada is the nation's only non-profit organization dedicated solely to the prevention and control of hypertension and its complications. Powered by a professional volunteer network of the country's leading experts in hypertension care, we pursue our mission through research, education, and advocacy. We produce Canada's clinical practice guidelines for hypertension, which are evidence-based, rigorously reviewed, and annually updated. And we offer accredited training in person and online to keep healthcare professionals at the leading edge of hypertension diagnosis and care. And that's why we're here today, hosting the Sprint Expert Exchange, which addresses new guidelines developed in response to the Sprint data. Sprint has significantly changed blood pressure targets in some populations. We have invited hypertension experts to provide context for some of the most challenging clinical judgments that physicians, nurses, and pharmacists are asked to make every day in their practices. Today's panelists participate as independent experts rather than as representatives of Hypertension Canada in order to provide latitude for a fulsome discussion in this new and developing area of hypertension science. It's my pleasure today to begin by introducing our moderator, Dr. George Dresser.
Hello.
Dr. Dresser is an associate professor and an active clinician in general internal medicine and clinical pharmacology at Western University. He also chairs a hypertension guidelines subcommittee on pharmacotherapy for hypertensive patients without compelling indications, and has been at the center of discussions about this year's Sprint-related guidelines updates. We are grateful to Dr. Dresser for helping to lead and develop the Sprint Expert Exchange, and I will now turn the floor over to Dr. Dresser to introduce the other panelists and to guide our discussion today.
Thank you, Angelique. It's my pleasure to introduce our expert presenters for today. You should be able to see disclosures on the slide. We'll leave those up just for a second. Dr. Stella Dascopolo, I hope I pronounced that correctly, Stella. I usually just call you Stella. Anyways, is an associate professor in the Department of Medicine in the divisions of internal medicine and experimental medicine at McGill University, and she is also the director of the vascular health unit there. She's also the current chair for the Central Review Committee for the Hypertension Canada Guidelines.
Hi.
Dr. Mark Gelfer is a clinical assistant professor in the Department of Family Medicine, or Family Practice at the University of British Columbia, and he's a family physician at the Copeman Health Centre in Vancouver.
Hi, everybody.
So in today's session, we will introduce the issue discussing what is the SPRINT trial, the systolic blood pressure intervention trial. We're going to briefly touch on the changes that have been made to the Hypertension Canada guidelines as a result of SPRINT. And then one of the really key issues in this study is the method by which they measured blood pressure, and that's really going to be the focus of our talk today. And then we'll have an audience question and answer session. You can submit questions at any time throughout the session by submitting a comment directly on the Hangout page if you're logged in via Google, or just send an email to info@hypertension.ca, and that's so info, I-N-F-O, at symbol hypertension.ca, and we'll try to get to some of your questions today. In the previous two sessions, we haven't been terribly good at doing that, but certainly we'll try for today. So the learning objectives for today's session are to explain the importance of regular, accurate blood pressure measurement to the outcomes of SPRINT. We're going to discuss incorporating regular, accurate blood pressure measurement in practice, and then we'll identify Hypertension Canada educational resources for participants today as well as patients to try to facilitate regular, accurate blood pressure measurement. So the SPRINT trial was a fairly large study run by the National Institutes of Health in the U.S., looking at the effect of intensive systolic blood pressure control to a target of less than 120 compared to standard control, which was considered to be a target of less than 140 in 9,300 patients. These patients did not have diabetes or stroke at baseline, and they were followed for a mean of 3.26 years. Next slide. The inclusion criteria for SPRINT were that you had to be over 50 years of age, you had to have an enrollment systolic blood pressure of greater than 130 and less than 180, and there were some criteria around how much medication you could already be on. There was also a requirement for some marker of increased cardiovascular risk. So that could be simply an age over 75, and about a third of patients had that as their main criteria for enrollment. You could have a calculated Framingham risk score of greater than 15%. You could have chronic kidney disease defined by an eGFR of 20 to 60 mils per minute, or you could have some other marker for clinical or subclinical cardiovascular disease that did not include stroke. Next slide. Oh, just the other point on this slide is that the patients were randomized 1-to-1 to the two treatment targets. In the next slide, we see the SPRINT mortality. What you can see is that after about 2 years, there appeared a mortality difference favoring the intensive treatment group over the standard treatment group. And this was actually the reason that the study was ended early on a recommendation from the Data Safety Monitoring Board, because they didn't feel it would be reasonable to continue a trial where the mortality difference was obvious. In the top right panel of this slide, you can see the blood pressure differences. And I'll just point out that the blood pressures dropped quickly over about a 3-month period of time to produce quite a separation in blood pressures, with an average blood pressure around 135 in the standard treatment arm and an average blood pressure about 121 systolic in the intensive treatment arm. If you flip to the next slide, it shows the primary outcome, which was a composite of both coronary and cerebrovascular events, as well as cardiovascular related mortality, and then stratified according to a variety of pre-specified subgroups. So the first thing you'll notice on the forest plot is that all of the point estimates of effect favor intensive treatment. You will notice that whether the patient had previous chronic kidney disease or not didn't make a big difference. Age over or under 75 years didn't make a big difference, although interestingly in this subgroup it seemed like the group that were over 75 years of age actually did better with the intensive treatment. Results didn't vary by sex, by race, by presence or absence of previous cardiovascular disease, and interestingly by enrollment systolic blood pressure. So there was a bit of a trend favoring the lowest systolic blood pressure readings, patients with the lowest systolic readings doing better over the course of the trial when they were randomized to the intensive treatment arm. So if you flip to the next slide, in terms of guidelines that we have now with Hypertension Canada related to this, we still say that a target of less than 140 over 90 should be attained in most patients. Because of SPRINT, we are now saying that that in high-risk patients, a systolic blood pressure target of less than 120 should be considered, and I think Stella will be talking about this in a few minutes. We say that in persons with diabetes, a blood pressure target of less than 130 over 80 is still recommended. And even though I chair the subgroup on pharmacotherapy, I'd like to highlight that targeting these measurements can be done using lifestyle modification and only if necessary with medication. So at this point, I would like to hand it over to, I believe Mark is going to start and lead us through a few slides directly related to this issue of how blood pressure was measured within the SPRINT trial. So Mark, if you, and feel free to comment on anything else that I've said to this point, and go ahead.
Thank you, George. I appreciate it. As George has already alluded to, many of the papers that have been published subsequent to the SPRINT publication have really focused on one of the key features of SPRINT, and that was the method of blood pressure measurement. So in the initial publication of SPRINT, the method was described as follows. Blood pressure measurements were taken as a mean of 3 office blood pressure measurements while the patient was seated and after 5 minutes of rest. And in the original paper, it was noted that the device used in all of the settings was an automated measurement system, the Model 907 by Omron Healthcare. To clarify and further emphasize the importance of this key measurement, where a group of the SPRINT key investigators published a commentary a couple of months later. So Bill Cushman and a group of these investigators published, could I have that slide back up, please? Sorry, published a further clarification, and that's, as they described it, it is important to understand that no matter who is chosen for application of the SPRINT intensive blood pressure lowering treatment strategy, it is important to be mindful of the manner in which blood pressure was measured in the trial. So again, an average of 3 office readings, patients seated with their backs supported, 5 minutes of rest before measurement, and very specifically they clarified that there was no conversation between the clinicians and the patients during the rest period or the blood pressure determination. Next slide, please, Felicia. Again, Cushman's group mentioned that this was achieved using this Omron automated blood pressure measurement device that was preset to allow a 5-minute rest before the measurement and then to take an average of the 3 readings. Next slide, please. There was further clarification a couple of months after the initial publication by Ernesto Schifrin and a couple of other authors in the American Journal of Hypertension, who again emphasized really the most important point, and that is that the method of measurement in SPRINT was performed using automated office blood pressure measurement and measuring the blood pressure 3 times unobserved. So these authors went back to the original SPRINT manual of operations and their central training manual, which called for the study personnel to actually leave the room after the device was set to 5 minutes before starting the measurement. And they further commented that this is critically important since systolic blood pressure, when measured this way, may be 5 to 10 millimeters of mercury lower than when measured with the observer in the room or when talking to the patient. Next slide, please. Myers and his group, in a paper that is now in press, accepted for publication, further emphasized this point and clarified it with Professor Cushman, who is one of the key investigators, and again pointed out that after the device was activated, research staff left the examining room with the patient then being alone for the 5-minute rest period and while all 3 readings were recorded. Next slide, please. Um, this editorial came just a few weeks later from Kario from Japan, who comments on some of the potential etiology or the cause for the more intensive blood pressure control, and also by virtue of the blood pressure measurement method. And as you'll see later, when Stella takes the microphone, Kario refers to some aspects of what we know as white coat hypertension. He comments that in current practice, several measurements of blood pressure are usually taken. Conventional doctor measured, and I would say nurse measured as well, office blood pressure is affected by the two aspects of the white coat effect. That is the person, the doctor or the nurse, and the place in the office setting. And this AOBP method, we believe strongly, and it has been shown in previous studies, as Stella will point out in a few minutes, that the AOBP method does exclude the doctor-induced white coat pressor effect. So his conclusion is the office blood pressure findings in SPRINT thus seem to be more similar to home blood pressure or ambulatory BP than to usual office blood pressure. Next slide, please. So Myers concludes by saying any concern that AOBP should not be implemented into routine clinical practice because it produces lower blood pressure readings by being more accurate and devoid of the white coat makes little sense and is scientifically unsound. Moreover, AOBP readings simplify diagnosis of hypertension by having the same threshold, 135/85 millimeters of mercury, for defining hypertension as both awake ambulatory and home blood pressure. And last slide, please. Dr. Schifrin and his group also concluded by suggesting that it's clear that optimizing the protocol for blood pressure measurement and optimizing control of blood pressure are evident conclusions that can be drawn from this study. Thank you. I'll pass it on to Stella to go through the next section.
Thank you, Mark. So let's see what we say in CHEP regarding the office blood pressure measurement methods. As we know, conventional office blood pressure is based on auscultatory or non-automated oscillometric methods and is attended, while the automated office, the AOBP, is unattended. So in 2015, CHEP revised the recommendation for office blood pressure measurement to suggest that measurement using electronic oscillometric upper arm devices is preferred over auscultation. So what is new in 2016? We now support AOBP as automated office blood pressure as the preferred method of performing in-office blood pressure measurement. And this was based on evidence that I will present in a moment. So just to summarize the principles of AOBP, the measurement is obtained using electronic oscillometric devices in the upper arm. And as you heard from Dr. Gelfer, the healthcare providers should not stay in the room. Multiple measurements are taken, and the mean blood pressure is automatically calculated. So in CHEP, we emphasize that AOBP is preferred to conventional office blood pressure. Sorry. I'm sorry, can you go, yes, can you go to the next slide? Sorry, my screen was black, so I couldn't see anything. Can you go to the next slide? Okay, and the next one, we mentioned all this. So as I said, in CHEP, we emphasize that AOBP is preferred to conventional office blood pressure because the latter would require the practitioner to stay in the room with the patient and repeatedly initiate measurements, or the other scenario is to walk in and out of the room and take serial measurements. So both practices are suboptimal because the risk of white coat effect is increased, there is increased risk of conversation with the patient during readings, and also because of the time constraints and the lack of patients, this will lead will prevent the practitioner to take as many measurements, multiple blood pressure measurements, as he should. Next slide, please. So indeed, studies have shown that the blood pressure that is routinely obtained in the clinic is higher than the standardized blood pressure obtained in a research setting. Specifically, the systolic blood pressure has been shown to be on average 9 millimeter mercury higher, and the diastolic blood pressure on average 6 millimeter higher, so 9 over 6. Next slide, please. On the other hand, AOBP values have been shown to be similar with awake ABPM measurement, ABPM values, as evidence in many different studies, and summarized by Myers. Next slide, please. Furthermore, it is important to point that AOBP is not affected by the setting in which blood pressure is recorded. Either this is an ABPM unit or in an office waiting room when it's measured with, when AOBP is used, the values are comparable with the physician examination room readings. Also, AOBP results in AOBP measurements that were obtained in the pharmacy were similar to AOBP results that were obtained in a physician's office. Other studies have shown also that AOBP is consistent from visit to visit. Next slide. Importantly, AOBP has been shown to predict, or is actually more strongly associated with target end organ damage than conventional blood pressure, and it's actually similar to ABPM. So specifically, systolic AOBP correlates with left ventricular mass index, similarly to awake ABPM. AOBP and 24-hour ABPM have similar predictive ability for microalbuminuria. And finally, when compared to conventional office blood pressure measurement, AOBP is more strongly associated with carotid intima media thickness. And this is the evidence that we had until last year. Can you please go to the next slide? Whereby results from the Cardiovascular Health Awareness Program study in Ontario became available. So the CHAP study showed that AOBP can actually predict cardiovascular events. So not only target organ damage, but now cardiovascular events. So specifically, the study that was published in the September issue of Hypertension, the Journal of Hypertension, included over 3,600 community dwelling residents. They were aged over 65 years who were untreated for hypertension. So the BP-True device was used for blood pressure measurements in community pharmacies. And participants were followed for a mean period of 4.9 years for the development of fatal and non-fatal cardiovascular events. Next slide, please. So they analyzed the data by using blood pressure increments of 10 millimeters mercury for systolic on the left-hand side and for diastolic blood pressure on the right-hand side. So they found that systolic blood pressure above 135 millimeters mercury was associated with an increased risk of cardiovascular events. And this risk is progressively higher with higher increments of systolic blood pressure, as you can appreciate from the increasing hazard ratios. So similarly, the risk is increasingly higher with diastolic blood pressure over 80 millimeters mercury. Next slide, please. So just to summarize the evidence, AOBP reduces white coat effect, is lower than conventional office blood pressure, and the measurements we get are similar to with awake ABPM values. It is not affected by the setting in which blood pressure is recorded. Importantly, AOBP predicts end organ damage, and more recently it was found that it can predict cardiovascular events. Next slide, please. So based on this evidence, CHEP modified the blood pressure measurement recommendation this year, supporting that AOBP is the preferred method of performing in-office blood pressure measurement. And at the bottom of the slide, you can see websites that present validated AOBP devices. Next slide, please. Together with this the recommendation that I mentioned, we also revised our diagnostic algorithm for hypertension. And the point is not to go through the diagnostic algorithm, which we will see in the upcoming publication in Canadian Journal of Cardiology of our guidelines. Actually, it's up to, I think it appears today on PubMed. But the point is actually to show you the third box where you can see that we actually suggest that AOBP is the preferred method for office blood pressure measurement for a diagnosis of hypertension. And the last slide, please. So coming back to SPRINT, SPRINT further supports the use of AOBP method, as you heard, in performing office blood pressure measurements, and strengthens our AOBP recommendation. So the new recommendation this year based on SPRINT results suggests that for high-risk patients aged 50 years or over with systolic blood pressure levels of 130 or higher, intensive management to target systolic blood pressure of 120 or lower should be considered. Importantly, intensive management should be guided by automated office blood pressure measurements. And patient selection for intensive management is recommended, and caution should be taken in certain high-risk groups. Thank you. I'll pass it on to George.
Great. So, if Felicia, if you have questions, maybe if you want to come on and you could actually just read the questions off. Otherwise, I guess my first question would be, what would you say to a doc who says, you know, this is great, I'm just going to keep doing the blood pressure the way I do it. You know, sometimes I'll measure it twice manual in my office when the patient's there, and I'll just add, you know, arbitrarily 10 or 15 points, and so the sprint target becomes sort of, you know, the intensive target becomes either 130, 135, and I know that's better than, say, 150, 155 in my practice. Because that, you know, that would be one potential extrapolation from the fact that we did the blood pressures the way we did them in sprint. What would you, any comments either? Mark, you're muted right now. You may want to unmute yourself there, but Stella, any thoughts?
We can speculate, but we cannot actually, obviously, that's on average in different studies, but any individual is individual. So you cannot actually, if this happened in epidemiological studies, doesn't mean it will happen to the person. So we have now the technology to measure blood pressure much better. We do not need to measure as we were measuring 100 years ago. So there is now new technology, and we have to take advantage in order to classify patients correctly, not over or underestimate. So because we can make mistakes in both. So why, if we can measure accurately, why you know, like hold it up on the light and you know, extrapolate and like blood pressure. So I think technology is available, and it's there for us to use it.
George, I would agree fully with Stella that you know, this trial is an important trial. It's really a landmark, and it does set the standard going forward. But in many ways, not just in targets, it also really supports and sets a standard for blood pressure measurement in the office. I think the corollary to what you just said and Stella just spoke to is really don't try, if you're a clinician, practicing clinician, to achieve this level of blood pressure control around 120 or less unless you are using really standardized automated office blood pressure measurement because we don't know what the potential outcome might be. If you're trying to reach that level with a different method of measurement, it could actually be lower than you think. So that would be my take on this.
What would you folks say to someone who says, you know, this push by Hypertension Canada to have everybody doing automated office measurement or ambulatory blood pressure measurement is going to push up the cost of looking after hypertension patients. You know, all these, if you have a family practice that's not set up with this equipment and now you have to invest and they see a barrier to investment, how would you respond to that?
My answer to that would be that there's clearly a cost benefit to doing it this way for the population, and that in the end, better measurement will allow us to do, you know, much finer and better control. We do have the medications, we do have the methods for controlling blood pressure, but without standardizing and taking really careful, accurate, reproducible measurements that are meaningful, it really becomes difficult to achieve. So I think in the end it's a true win-win-win for patients, their clinicians, and their insurers if we do this, if we all do this properly.
I totally agree, and there's actually cost-effective studies, especially in Ontario, and then they have shown that if you classify the patient correctly and you treat them properly, then it's actually cost-effective to invest a small amount towards, you know, like measuring properly.
Sure. There's one question here, and then I think we'll finish up. So the question is, I'm a pharmacist. We have a separate room with a calibrated kiosk. What would you say about a pharmacist who's taking measurements that differ from what the GP is getting?
Well, higher.
Oh, they don't say whether they're higher or lower.
My answer to that is that what this pharmacist is seeing is really out of office blood pressure measurement. If the pharmacy kiosk is calibrated and accurate, and there are some definitely that have been shown and proven and published to be independently to be accurate, then that is more representative of an out-of-office measurement and should be taken very seriously. That might be a good setting to perhaps recommend having an ABPM, an ambulatory blood pressure measurement test done, or some other corroborative testing.
And we have actually evidence towards that. I agree totally with Mark. So the CHAP study that I mentioned was based on blood pressure measurements using AOBP, specifically BP-True, in pharmacies, and they showed the measurements that they have. There's better predictive value in terms of cardiovascular events. So we actually have evidence from the pharmacy that if
Right.
they are taken correctly, then they're very, very important measurements.
Right. Yeah, and our group last year published a paper looking at patients seen in a hypertension unit who had AOBP and 24-hour ambulatory, and then did a series of pharmacy readings using an accurate pharmacy kiosk, a kiosk that's been shown to be validated and accurate, and we showed that the average of those readings can be very, very similar to the AOBP and the daytime average ambulatory. So it is definitely a potential.
Yeah, exactly. As I mentioned before, the AOBP.
So again, thank you all for joining us today, and hopefully the rest of your day goes well.
Thank you.
Thank you. Thank you.